Thank you, ma'am. Thank you very much for having me here. Can I have some of those panelists back here? So, Doctor.
Dr. Hing, can I call Dr. Hing Mere to co-chair the session, please?
So, Dr. Borkar, please. Dr. Tanuja Seth back. Dr. Aparnadhar back. And can I have, please, Dr. Poonam Patil and Dr. Rima Pathak here, please. Thank you. I think they don't need introduction. So, and I've been already warned that time is limited. So, we shall go straight on to a very interesting discussion. I think my starting point here is that the only thing which is constant is change. And I think of all things in at least 10, 15 years that I've been working, oligometastatic disease is truly changing and is now become a very important part of all cancers. But let's start with some definitions first, because I think that remains a question, and we'll start polling straight audience as a whole. How many do you consider oligo? Sorry, ma'am? No, I think there are just 5 of us. At least that's what I've been told. Dr. Poonam Patil is there? Yeah, okay. So, in fact, there were some who thought that as many as them can be treated. 5 gets about 6. Generally speaking, oligometastatic disease, most literature will consider 5. I think this number came from nowhere, but it's 5. There is some initial research which looked at 1, 2, 3, 4, 5, and the 5 had separation of curve, but 5 is considered usually the right number. Can I start with Dr. Patil? Dr. Patil, what do you use as an oligometastatic definition? I put some labels there also. Synchronous, metachronous, oligorecurrence, oligoprogression, a very interesting one, induced oligometastatic disease. What's your view on this, ma'am?
Oligometastasis, by definition, is up to 5 sites of disease in confined to one organ.
Okay, in confined to one organ.
One organ, up to 5 sites in one organ.
So if you had a single, maybe 1 liver and 3 bones, that would not be oligometastatic in your practice. I think there are various definitions.
I think it's one organ, 5 sites.
Okay. Nikhilesh, what do you do in practice?
No, I would consider any site, but less than sometimes up to 3 if it is multiple sites. Otherwise, up to 5 I take as oligometastasis.
Okay, Rima?
So I guess the astro is to definition. As a radiation oncologist, I would vouch by that, and that does not limit the number of organs. But typically, up to 3 organs is what people follow. Like if you have 1 in the brain, 1 in the lung, 1 in the liver, 1 in the bone, I don't think that really qualifies.
Okay. So I think what we can always see, there is a difference in opinion, which is good, because that shows that we need to individualize each of these patients. And what we are not talking about here is that it's not just the number of sites and the number of meds, it's also what we are seeing as the biology of those sites and those meds, and that's so individual. And this is very important because the definition of oligometastatic and oligorecurrence not only has an implication on response to therapy, survival of these patients, but differs between lung cancer and breast cancer. In lung cancer, if you are presenting with a synchronous metastatic disease, your outcomes are in fact worse than recurrence. But in breast cancer, there are at least 2 studies, maybe more than that. In fact, the one on the left is from Chennai itself. We can see that patients who present with an oligorecurrence after having had radical treatment, in fact, do better. So not only is there a discordance amongst the number of location, number of sites, but also about different disease patterns. And therefore, I think it is about individualizing, and that's really the crux of the oligometastatic disease, which is patient selection and prognosis. So I'll very quickly just put this very busy slide, not to highlight anything in the slide or the next one, but just to say that there's been a lot of study which has looked at various parameters, both in journal oncology, radiation oncology papers are there, because I think there's a lot of field commonality here which talks about this. So with that, can I start again, maybe with Rima again and maybe go leftward? Or how do you select that patient where you feel that a radical treatment, and we'll talk about the radicality, what all it entails, is very critical to outcomes in this patient? How do you select?
So I think as of now, we have in Tata Memorial taken a stand that for most oligometastatic patients, we will try and provide radical treatment. So long as the breast itself, so the primary disease is operable, then we go ahead and call it a radical treatment. So what you have to understand is that some patients will require either radiation, some patients may require surgery for that oligometastatic, as an oligometastasis directed therapy, but you can provide that treatment. However, after treating so many patients of oligometastasis with radical intent, we also realize that not everyone is going to have benefit. We do see patients come back even on their first follow-up with this polymetastasis right after finishing their oligometastasis directed therapy. We still don't have a biomarker here.
Can I pass that to Tanuja? So, in your understanding of this, what are the biological? Because that's what Rima was just talking about. What are these biological aspects of the tumor? Because there is a lot of data that, as I said, I'm not going through rummaging through the details of that, which explain to us who are the patients we should pick up for this maybe somewhat quasi-radical approach.
So, just to kind of have a gist of it, of course, the biomarkers of the tumor itself, the ERPR2, we know that for ERPR having a better responsive disease in an oligometastatic situation, the chances are higher. So there was some paper, again as I said, I have not read 2022, where the proliferation even in a ERPR positive tumor predicts your response to, whether the patient should get only radiation or chemotherapy and stuff like that. So that becomes relevant, that how proliferative your tumor is and versus the biomarkers. So if you have an ERPR positive tumor, but if it's very high MIB1, then more than any local disease, those patients tend to respond more to systemic therapy. So just a thought.
From response point of view, but actually from survival point of view, it may be the other way around.
So obviously the biomarkers take the lead.
But I still don't think there is any mainstream biomarker available that you can use for patient selection in oligometastasis.
They aren't, but you see what I'm trying to show here is that there is a lot of multivariate and univariate analysis, which, and maybe Dr. Bolkar, I'll take this to you, there's a lot of analysis which is talking about how to segregate the good group from the bad group. I mean, if you look at this, there's a hazard ratio of 0.18 in HER2, in hormone receptor positive and HER2 positive disease. That's a very big hazard ratio drop by just looking at the hormone positive, like Tanuja was saying. In fact, if you look at DFI, that's again a very significant number. If you look at the progression-free survival, complete responders do better. So there is study out there. In fact, there's a scoring out there which went defunct because it could not be used prospectively. But there are studies out there which help us pick up that patient where even in hormone receptor positive, therapy works. So how do you do this in your clinical practice?
Especially if it is a solitary met or if it is a bone predominant met rather than liver or lung, those patients are going to do well. So those I select for radical treatment. Others, I give them systemic therapy upfront and see the response. If they are very good response, even if with multiple metastasis, they get induced oligometastasis, still I may offer radical surgery for them. But otherwise, it's not a great prognosis even with ER positive for oligometastasis.
That is a slightly difficult one but yeah, fair enough. Aparna, is there any molecular marker that we can use for these patients? Do the BRCA and the PALB2s and the ATMs do better in terms of?
The BRCAs definitely do better, but I don't think there's sufficient data for PALB2 and ATM.
Okay, and anything else?
There is some data about liquid biopsy in oligometastatic patients where I think HER2. So there is some data on that if you have, I'm not very sure, but if you have one excess of HER2, you have mutations in HER2 circulating in the tumor cells, those patients do bear vis-a-vis negative.
So that's actually lobular, oligometastatic lobular. If you have ERBB2 mutation in your circulating, they do worse. it's a worse prognostic feature despite of being bone only and despite of being ER positive and despite of being low Ki67, they do worse. But I know there's a lot of work going on CTC, for example, in oligometastatic disease also to pick up the right patient for the right job. With that, we'll come to the case. This is a very interesting case. And there's a climax here in the last slide, but we'll come to that in the end. So this is a 58-year-old woman who has a family history of a maternal aunt with uterine cancer, but really not else. This is distant aunt. And had a history of bleeding and asymmetry of her breast for over 18 months. I prodded, when she first came to clinic as a second opinion, the history was that she had the lump for 2 months, then I prodded, it became 6. As I prodded more, it was at least 18 months. My guess is it could have been longer because it was very large and huge. So she ends up with a biopsy which shows papillary neoplasm. Tanuja, this question is obviously coming to you. And we did a PET, as we do in this part of the world more often than not. And this is what it shows, and I'll come to that. Tanuja, papillary neoplasm, what are you thinking about this patient as you read this biopsy?
So this is a panel on oligometastatic, right?
We haven't said oligometastatic yet.
I'm sorry. So, as far as I can see, this is a PET CT and it's showing a cystic mass clearly. So, I have never seen papillary neoplasm metastasize the way, but recently the spectrum is changing. Like just the other day, I had to scratch my head. We had a male breast cancer with a encapsulated papillary carcinoma with a solitary brain mass. Wow. And I can't fathom how, I was thinking, is this something else? And I wasted a lot of time on that. So papillary tumors do not, but they do produce oligometastatic disease, single limited disease. That's what I have learned. So the way I would think is this is invasive papillary. The problem with papillary tumors is you've done a core biopsy.
Yeah, it's a core biopsy.
Yeah. So what happens in a core biopsy is people are worried that what is there in the rest of the specimen.
That's exactly actually what I was coming to. That would you question the biopsy if, of course, the oligometastatic disease so give away, but if you had a metastatic disease, which I'll show next, would you question the biopsy again because it's papillary?
So we can fairly say whether it is benign or malignant on the core biopsy.
Yeah, sure.
So as I said, if it was a histology like in the past, it was encapsulated papillary carcinoma on a core. So we do classify papillary lesions on core biopsies. But if for patients whom we have details available, so if you send me a biopsy without any history, I give papillary neoplasm and you will see a nice footnote saying that this is most likely a papillary carcinoma, but I need this information. So we do, because presence of myoepithelial cells in a papillary neoplasm means that it is not malignant. So that simple question we can decide for you. If there is absence of myoepithelial cells, we can tell you it's a papillary carcinoma. It may be limited or it may be extensive. That I can't tell you on a core biopsy, but I can tell you it's a carcinoma. So that situation can be solved. But as I said, till recently I would worry if somebody tells me metastatic disease and I'm getting a papillary carcinoma in the breast. But we are seeing cases. We are seeing with oligometastatic disease with papillary carcinoma.
What about tubulars and mucinous in the same?
Sorry?
What about the tubular carcinomas and the mucinous carcinomas?
You should never utter the word mucinous in front of me because then I go berserk.
Okay.
So I will leave it.
Take my word back.
It's a trigger fight. All the TMH team knows. I will tell you that later because that's a big story.
Okay.
Tubular, yes. They do, but as I said, I remember Dr. Sareen once saying we had a tubular carcinoma and she had a oligometastatic bone in the clavicle. So he called me, Tanuja, I've never seen oligometastatic and tubular carcinoma, you better check, and it was a myeloma. So yes, tubular never produces this kind of situation. Mucinous is a different story. And papillaries I have seen recently coming up with oligometastatic. Others papillary don't produce these unusual sites. But I don't know what it is, but recently we've seen such odd histologies.
COVID.
So yes, I would question it. I will make sure that there is no myoepithelial marker and it is indeed the lesion that has produced the metastasis.
Oh, thank you. I think that's what I was looking for. I was saying that we blamed everything on COVID. Maybe you can blame that on COVID also. So this patient, as I said, the PET scan in fact showed a single metastasis. Dr. Patil, what should you do next?
So the breast mass is a big mass, and but no nodes that I could see. So there are two sides of disease here. And as doctor said that we should confirm the pathology of the breast and probably the vertebral body, not the body, the lamina area also looks to be the same. And both, if could be treated radically, one with surgery and another one with radiation probably.
No, I will come to that, but next you would like to biopsy the bone.
I forgot to tell that.
So we did biopsy this. We did FNAC, we biopsied this, and it turned out to be an adenocarcinoma. The ER is 8, PR 8.
The breast one.
Breast, this is breast, in fact. The biopsy is just adenocarcinoma, the IHC was not done. The ER 8, PR 8, I will... So this is the summary of the case. So she had a 10 by 8 by 8 centimeter lymph node of the armpit was negative on FNAC. PET CT showed isolated bone mets. On biopsy of the core biopsy of the breast, it's ER8, PR8, HER2 0, Ki67, 18 to 20%. Is that acceptable, Tanuja?
Yeah.
Okay. So I'll start with the surgical team. Dr. Bodkar, what would you think we should do in this patient?
I would go for upfront surgery because it is a solitary bone met which is present.
I'll pause you there. There was a polling question here. So I want everybody to participate in this on what should one do primary treatment of oligometastatic disease. Talking about the breast here. Should breast be operated in this patient? Okay, so I think majority saying yes. There is a minority of 9 people who feel not. Yes, Dr. Bolker, please, I'll let you continue.
Yeah, the Turkish trial also said oligometastatic solitary bone met with hormone receptor positive. They should be undergoing surgery. If we see the Tata trial which was done, they had not taken the oligometastatic. They were treated radically. So for oligometastatic papillary carcinoma, good prognosis, I will go for surgery for the breast and SBRT or surgical resection, whatever is feasible for the bone marrow.
Did we retrospectively look at from Tata, I mean we have both a few years, did you look back at oligometastatic group there? Yes, please.
Like Tanuja said, some things are just too personal for us. So the TMH study has a stratification of less than 3, more than 3. The less than 3 are not oligometastatic disease. They are multiple organs. None of them were treated with radical intent. So we do not have oligometastatic patients in that study really. And we have our own audit running. RIMA has a registry running prospectively on oligometastatic and our outcomes on that separately.
But the ones which were less than 3 who did not get radical treatment, now with the latest data coming out,
so there's follow-up also which is going to come up in the meta-analysis. There's no difference.
We'll know with time. But I think the point you were trying to make is that there is again discrepancy there. But the most of the world where there is discrepancy is not looking at oligometastatic disease in particular. It was a mixed bag. And I think we all know through our clinical practice with mixed bag, there is a problem. Dr. Patil, do you have a view on this, on how should we be treating primary in a patient with oligometastatic disease? This one was somewhat simpler. This is papillary, single med, but this is not common. The true oligometastatic we see in clinic, we've got one liver, one bone, and the lymph node somewhere sitting very far from primary.
So the spectrum could be varied from a very good biology to the poorest one.
Hormone receptor positive, HR positive, HER2 negative, but metastatic disease slightly spaced out, which is the commonest thing I see at least in my practice.
So I would treat them radically with surgery and targeted radiation to the bone.
So do we have an agreement amongst panel of Aparna, including you, that if a patient has a very limited disease and a good biology, we should actually operate the primary? Anybody in the audience who has a contribute to that? So at least we can close out on this. Should we treat the primary? Yes, no, maybe is actually a yes. So oligometastatic, good biology, we are agreeing to this. Now if primary is treated oligometastatic, hormone receptor positive, should we give systemic therapy first or systemic therapy later? This is again a polling question. So oligometastatic, hormone receptor positive, chemo first or systemic therapy first or systemic later? Oh, systemic first. Okay, so that's very interesting. Dr. Patil, can I start with you again on this? What would you do and
Yeah, I would also start with systemic therapy first, but during the course would also go on with surgery and radiation.
and which systemic therapy, ma'am? I mean, I'm coming to that also, but since you're talking about which systemic therapy, you start with chemotherapy or hormone therapy?
Not chemotherapy.
You wouldn't start
Hormone therapy.
hormone therapy in this
Because that would not that will not stop me from doing surgery or radiation, and it would just go on parallelly.
How long would you use that before you?
It is a metastatic disease, so I would not
Okay.
have that answer to how long I will continue.
So you'll see the response and then you'll
Yes.
take a call.
Yes.
Okay, fair enough. Dr. Bodka, would that be a practice, or you'd say in your hospital as a board that we'll sit on this for 4 months or 6 months, give.
So sometimes if it is a oligometastatic solidly, I may sometimes offer surgery first, but most of the times it will be systemic therapy. I would offer hormonal therapy along with CDK inhibitor, especially in postmenopausal women, and see the response at 3 to 6 months. If the response is very good, then we can go ahead with surgery.
Rima, what about your?
So I think we need to first decide whether we are going to treat this patient as a patient who has metastasis, or we are going to treat the patient radically
What would you treat
So
this
in our
patient?
practice, we treat these patients just like any other locally advanced breast cancer. She will receive chemotherapy first, which is the standard AC taxanes chemotherapy, and then subsequently undergo surgery. Now there are several advantages to this approach. One is that you will understand whether this biology that we are looking at is
And you're speaking
chemosynthetic.
generally about these patients or this patient in particular?
No, these patients.
Okay.
So I'm not talking about this patient in particular. Maybe the medical oncologist might prefer to give neoadjuvant hormone therapy. Again, that is not very conventional approach. So these patients, there are some, like I was saying, there are several advantages to giving chemotherapy first. One, you will know whether these patients are sensitive to systemic therapy, because many of these patients tend to progress. So while we may have picked them up earlier in their progression, these metastases do manifest and these patients progress. So if you would have treated this patient radically, you would have wasted that patient's time, energy, money, given toxicity, but no advantage.
So what I'm hearing is some neoadjuvant therapy first,
Yes.
so that you start controlling the further
Yes.
progression, and then pick up the good from the bad group and then operate on the good group. That's the kind of approach that I'm
Yes,
hearing.
I think Neeta would agree. We do see some patients where we would have seen only one bone metastasis, but after neoadjuvant chemotherapy, when these patients come for radiation, finally after surgery and everything, we find that there are specks of multiple metastases elsewhere as well.
Where I'm struggling with here, and I can't see Shona, maybe I can see Chetan. Okay, Shona is there. So Sudeep is also there. What I'm struggling with is that we've got a hormone receptor positive, and this is not uncommon. We're only talking hormone receptor positive oligometastatic disease here. And we have a patient with an oligometastatic bone lesion, and we are saying systemic therapy first. And now the debate is chemotherapy or hormone therapy. And we know many of these patients with strong ERPR positive, even if not papillary, have very poor responses to chemotherapy.
In fact,
So,
papillary, I was just about to tell that Nitesh that papillaries don't respond, means you don't respond well to chemotherapy.
Absolutely.
So in this case, you have a diagnostic problem because there is some report that you have. No, if you have to look at this case, you have a papillary neoplasm report. So, and you don't have anything that tells you not to operate, so you probably should go operate first and then in this case. But
yeah,
overall,
I agree. So that's why I asked Hima that are you talking philosophically, which is maybe a better discussion to have rather than in this case. This case is maybe a bit more straightforward. But philosophically, as I said, we more often see hormone receptor positive, low Ki67, grade 1, grade 2 tumors, grade 2 very commonly, a small metastasis in the bone, 1 or 2 spots. And the question comes up in tumor board again and again of systemic therapy first or later. And is systemic therapy first? I said non plus. I don't want to give these patients chemotherapy. But there is a whole logic to say give chemotherapy first, you're not going to get later. but they don't respond. Shona, Sudeep, do you have a view on that? Your mic there, please.
So I was just having this discussion with Neeta and Seema that the local site is important. So if you've got these two mets, you've got a biology of a tumor that is not very responsive to cytotoxics, and you can get away with good local therapy, I would just, in this particular case, do the local treatment and perhaps put the patient on hormones.
Okay, so you're saying maybe not even consider neoadjuvant approach. We do not need to, because that's what I was hearing from Nima, that pick up a neoadjuvant systemic therapy approach, select the good from the bad, the good go in for local therapy, which is a very logical approach, and what you're saying is also very logical, that considering not giving chemotherapy, let's operate first and then do everything later. Sudeep, do you have a view on that? You agree with her? So we would operate these patients?
So I think will vary from one patient to the other and the specific context of the patient, but in general I agree with what Shima said, that if you are not going to give this patient chemotherapy, you might as well operate on that patient first. If there is a single or two sites of bone metastasis, one can operate on that patient and then decide the systemic therapy later on.
So the debate starts that we change our opinion when there's a same biology, 4-5 lymph nodes sitting in the armpit. That's where the debate starts. And because this is metastatic, and only the metastatic is one level higher, so I'm really confused. I'm actually accepting.
So I'm going to ask you that leave the meta side. She doesn't have a bone met. You have this patient with a 10 centimeter mass, she's papillary CA, ERPR positive, HER2 negative, Ki67,
this one is easy.
18%.
No, I said
So that's what I'm saying. So I think what Seema is trying to say is that one would do what you would do without the met. The biology and trying to define the biology of that met, we would do that definitely more for a visceral metastatic site. For a bone-only metastatic site, you've got evidence from randomized studies which tell you can operate up first. That's the Turkish study. It was surgery first, followed by local regional therapy. If you're not going to give this patient chemo, irrespective of that metastatic site, that's the treatment protocol I think that we follow.
So let me summarize what I've, sorry, yes.
So I had a question. In this particular situation, this lady has got a large mass with a single bone metastasis, good histology, no nodes. Would you be willing to offer her breast conservation?
So 10 centimeter mass,
No, with upfront treatment.
With upfront systemic therapy.
Yeah. And with that upfront, suppose she shows a desire.
So if she's amenable to breast conserving surgery, I'm going to treat her the same way I would treat a locally advanced cancer.
Exactly.
That's the point.
There's no contraindication to breast conservation just because of oligometastasis.
So exactly. So if she is desirable for a breast conservation and it is possible, then will the upfront systemic treatment change?
So the medical oncologist has to be planning to give chemo. If the medical oncologist feels that because she's ERPR positive, low Ki67, they don't want to give chemo at all.
No, but I accept if a patient insists that I want a conservation and you feel that absolutely is possible, we'll give neoadjuvant hormone therapy for that case. But that can't replace for the fact that you have to give chemotherapy because you're doing neoadjuvant therapy. I think that's the point I'm trying to get across.
So I also want to know how many medical oncologists would actually do neoadjuvant hormonal treatment, especially with just one metastasis. Very, very unusual.
More and more, but not enough.
So that's the point. So you have to treat, just as Neeta said, treat her like a locally advanced breast cancer because you're defining an intent. When you say there is a single met, your intent is cure. We are gunning for cure, not for control. If it is control, then do your hormonal.
Okay. So let me summarize what we heard in the last 5 minutes. So if a patient is biologically not chemo responsive, upfront surgery is the most logical way of going forward and then manage the systemic therapy. Otherwise, obviously, it's a personalized approach. So this can't be a dictum for everybody, and that's exactly what happened with this patient. She went for upfront MRM with ALND, can I have Dr. Borkar, your opinion, should ALND have been done? This was a node negative, FNAC negative, or sentinel would have sufficed?
Sorry, didn't get the question.
This patient underwent ALND. This was a FNAC negative. Would sentinel lymph node biopsy would have sufficed? Or ALND was a must considering this was a 10 centimeter tumor, but papillary, but metastatic?
Chances of METs even with a 10 centimeter will be about 30% if imaging is negative. So I would still proceed with the sentinel node.
Sentinel node?
Yes.
Okay. So she had ALND and it turned out to be an encapsulated papillary carcinoma of the right breast, grade 1, T3 and 0. And a question is obviously what next? Can I start with you first and then maybe Dr. Patil?
I would still give her adjuvant chemotherapy for whatever benefit. The benefit will be very less because it's an encapsulated papillary. I agree. But at least 4 cycles of TC I would consider for her because of the MET and the T3 tumor. Okay. And then the hormonal therapy.
Okay, and you said chemotherapy followed by radiation. To what? To the
chest wall.
Just the chest wall. And the metastatic side?
SBRT I would consider for that.
Okay. Dr. Patil?
Yes, so I agree that we would put her on radiation to the primary and metastatic site, followed by adjuvant, so-called adjuvant treatment.
Okay, so I've heard two views. Rima, I'm not holding you back. I'm going to ask you more questions. So, radiotherapy to the primary site, radiotherapy metastatic site or not to primary site. You've done a radical treatment, yes, no, or maybe. Can we poll now, please? Okay, so radiotherapy to the metastatic site or sites, majority of people say yes. There is some no, and maybe Rima, this question is for you. Both, I'm guessing the primary site is not so much of a contention. Sometimes it may be. So where would you not radiate the primary site, if at all? But the question is mainly the metastatic site. And we know why this question is. It's because of this trial which came out this year. And I think in context of that, what we do now?
So we still don't have the full paper, and we don't know what went wrong, because across the board, if you see, and I agree that breast cancer is different from other cancers, but across the board you see prostate, you see lung, you see renal, you see that there is difference in DFI, there is difference in OS, and you're not seeing it here. So we don't know why this
is. We're not seeing this. They stopped the phase 3 component.
I know, it's not moving on to phase 3. So they've stopped it at phase 2 itself. Their ctDNA component is also negative. So all subgroup, all the sub-studies are also negative. So we really don't know whether the patient selection went so terribly wrong that this is what we are seeing, or what was it? Was it visceral more, bone less? I don't know. So unless and until the full paper comes in, we are still continuing to practice. And we will provide locoregional therapy as well as oligometastasis directed therapy.
Anybody in the audience have a contrary view who's very influenced by this paper? I thought it was very interesting. I thought it was very interesting that the radiation in a good biology group, this was a good biology group, to the metastatic site did not have an impact in an oligometastatic disease. So I thought in that respect it was very interesting. Bhavna, are you making a comment? You're just coming in. I was very happy Bhavna just coming to make a comment. Maybe you can. So this was the question that came in 2020 with the NRG BR002 trial, where they said that if you've got a good biology, oligometastatic, radiation to the metastatic site did not make any difference, and hence the phase 3, after phase 2 randomization, phase 3 they are not going in for. So far we've been actually saying if you're treating radically, treat everything radically. In fact, that some definition of oligometastatic head, treat the metastatic site. And this changes the whole concept. And she's right, we don't have a full paper. Would you change your practice till you get the full paper out?
So I think till even today we do radiate the metastatic sites as well. And in fact, in the current advanced ABC guidelines, that is what they say, if you're treating radically, you would radiate the metastatic sites.
Okay, so
So it's not just radiation, it is also any ablative therapy.
Yeah.
So it could be surgery, it could be radiation, it could
RFA
be
as well.
RFA, yeah.
Okay, so this is at least clear. This was a fairly provocative trial, and I think till at least on this segment, till more data is available, this was first study, till the full paper is out, till we know more, I think our standard of practice will remain what we've been doing, which is please radiate the metastatic site, or not radiate, but treat the metastatic site radically. So now we come to a very interesting question, which is the choice and sequence of systemic therapy. So I have 4 minutes. I'll go quickly through this. Question 1 is systemic therapy, chemotherapy or not. I'm not talking about only papillary. I'm talking about oligometastatic, hormone receptor positive, ER/PR strongly, low-grade tumors. Yes, no, maybe. Can we vote on this? Okay, I think voting is a problem. Show of hands would give chemotherapy to this patient. Okay, yeah. So chemotherapy, yes, and let's vote again. Can we have another voting, please? Which is CDK4 inhibitor in systemic therapy, neoadjuvant or adjuvant in this category of patients. Yes, no, maybe. And yes again. Dr. Patil, how do we sequence? Most people want to give chemotherapy and most people want to give CDK also. What would you do and how do we play around with this? This is becoming a very difficult area.
Yeah, it is difficult for me as well. But if I am asked to do, probably I would stick to hormone therapy.
And skip even just a taxane chemotherapy for many of these patients. Okay. What do we do at Tata on these patients in the board?
We don't give CDK4/6 inhibitors. Like Neeta said, we will treat all of these patients just as a locally advanced breast cancer and not treat as metastatic cancer.
So you would not give chemotherapy, you're saying?
No. So in this particular case, we may not end up giving chemotherapy.
Yeah. But
yes.
But generally, if you get a hormone receptor positive, node positive, or oligometastatic patient, which is not papillary and not tubular, would you give this patient
chemotherapy followed by hormonal therapy? Yes.
And CDK?
No, not
Dr.
CDK.
Patil?
Not CDK.
Abemaciclib, adjuvant, the curves are still separating.
Yeah, if I look at that way from Monarch E standpoint, yes, probably, but I don't have that as a regular practice yet.
So this was just a very quick callow study. This was not oligometastatic, but it kind of principally showed that while chemotherapy did have benefit, when you looked at the ERs, positive and negative separately, in fact the separation of curve completely disappeared. And so I think it does make a big question of whether we should be doing this at all or not. This patient had, as we said, a papillary, encapsulated papillary carcinoma. Aparna, this question to you. I did not. But somebody sent Oncotype DX for this patient, and this was the score. Aparna, your views and then closing remarks from everybody on the panel. So,
low risk. I would not even just.
Can we interpret this first of all?
I wouldn't want to.
No. Okay. But I think I have a more interesting question here. We've been talking about biomarkers from when we started about oligometastatic disease and in fact in triple negative also. So considering that Oncotype DX was not, it's actually a biomarker. I think maybe Dr. Seth can opine on this also, but it's a way of biomarker deciding who's chemosensitive or not, more than who's got a risk or not, isn't it?
So see, the encapsulated papillary, you're not going to get. It has the lowest chromosomal instability. Okay, it's a very good tumor. We looked for so many things in encapsulary papillary. It has absolutely low mutation profile. So to do anything with this tumor is excellent.
But may I make a comment? Nitesh, but these patients were not included in the study.
They were not included. Oncotype should have never been sent. All I'm saying is
you sent it?
No, I didn't. I made a disclaimer, I did not send it. I have removed the name of the doctor who sent it, but that's not the point. The point is that should we use biomarker? I am running short of time. This patient had relation to local site and isolated bony mets and is on letrozole alone. We have not given CDK inhibitor yet. And as I said, the only things that constant is change, and I think we are changing. Thank you with that.